Here's the atria, here are the ventricles. So here's the SA node, here's the junction. And here is the conducting system to the ventricles, the left bundle and the right bundle. And the left bundle has some other branches, as we're going to hear about. All right, well, first let's say that you have a conduction disturbance which is functionally between the SA and the AV node. What would you call that? Does anybody know what you would call that? Suppose you would. That would be AV block, right? AV block or heart block, right? Okay, so heart block, and there are three types of heart block, right? Called first, second, and third degree heart block. Okay, what's first degree heart block?
Prolongation of PR.
PR prolongation greater than what? 0.20 seconds. Yeah. PR greater than 0.20 seconds. And as you remember in the electrocardiogram, that's 5 little boxes, right? So the PR should never be longer than 5 small boxes at normal paper speed. Right? Okay, so that's first degree heart block. Okay, second degree heart block. What's second degree heart block? There are two types of second degree heart block, right? Which are called, Mobitz 1. Mobitz 1 and Mobitz 2. What's Mobitz 1? That's the Wenke-Back phenomena, right? Mobitz 1 is the Wenke-Back phenomena. And the Wenke-Back phenomena, right, exactly. The PR interval gets longer and longer until you finally drop a beat. So here's first beat, and the PR gets longer. May get longer yet. And then finally, you drop a beat, and then you start all over again. So you can see here that your PR is getting longer and longer until finally you drop a beat entirely, and then you start the cycle again. Okay, progressive lengthening of the PR interval until you drop a beat. Okay, that's Mobitz 1 now. What's Mobitz 2? Okay, it's usually a fixed PR interval associated with intermittent dropping of beats. And it can be a 3 to 2, a 3 to 1, 2 to 1, 4 to 3, any type of ratio, but the PR remains usually fixed. Okay, and then what's third degree heart block? That's complete heart block. Okay.
Mobitz 2, any type of ratio, or is it, if you have greater than 3 to 2, is it considered third degree heart block?
No. You'll see now that the difference is, if you look at this, first degree heart block, every beat's conducted, right? Second degree heart block, some are conducted, and third degree heart block, none. Okay, that's the basic differential, right? So in the second degree, we have the Wenke-Back phenomena, which is progressive change in the PR interval, and then with the Mobitz type 2, you still have an intermittent conduction, non-conduction type situation, but the PR interval remains fixed. So that's the real differential between the Mobitz 1 and the Mobitz 2, is the fixed versus the non-fixed PR interval. Okay, is there any question about heart block now? That's heart block in its simplest form. I want you to remember that there's a difference between heart block and AV dissociation, and we'll be talking about that a little bit more.
The second called incomplete block, and third is complete block.
Right, you could call it that way. You could divide this up, as he said, into incomplete block, and here complete block, if you wanted to. All right. Now let's take another situation. Let's suppose that you have intact conduction between the atria and the ventricles, but let's say in addition you have an extra pathway which comes around here and excites the ventricles, or let's say goes all the way around this side, can do that as well, and excites the ventricles. It's sort of a bypass or accessory pathway. It's not really a bypass, it's an additional or an accessory pathway, so that you start activating the ventricles in this manner, and activation proceeds in a transmural fashion. Well, this comes down, continues down, have activation. Finally, enough time has elapsed so that the rest of the impulse, which is traveling down this pathway, rather than down the aberrant pathway, finally gets it to the junction, and then you have depolarization of the heart in the normal manner. Right? So you have depolarization of the ventricles taking place in two different directions at the same time. One coming down an aberrant pathway, and the other later on coming down the normal pathway. Okay, well, we could diagram this, right? This is normal electrocardiogram. What we have in this situation going on here is we have atrial depolarization, same thing. And then as soon as the atria are depolarized, there's no delay at the AV node, so this aberrant pathway is traveled upon, right? And so what you start to see is this aberrant transmural spread of activation, right, which is slurring. Slurring, it takes a long time. Okay? And then finally, as the impulse travels a normal pathway, you see that they meet, and the rest of the QRS complex is normal. Right? So the rest is normal, and there may be a secondary change in the T wave, actually. So what do we call this? Right, this is the Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome. And we can just look at this and we can set up our own criteria for this, right? Which would be what? What criteria? Short PR, okay. So number one is a short PR. And by short PR, what do we mean by a short PR? Less than what? No, 0.2 is the upper limit of normal. 0.12, right? Short PR, that means less than 0.12. Okay, what else? Prolonged QRS, good, that's another criteria. What do we mean by prolonged QRS? No, 0.20, that's the upper limit of normal for the PR.
Greater than 1.10.
0.10, greater than 0.10. You have to learn your intervals, otherwise you're lost. Greater than 0.10. Greater than 0.10 seconds is a prolonged QRS. Okay. And any other criteria, anybody?
Slurring of the
Yeah, which is called a what? What is that slurring of the upstroke called?
delta wave.
Delta wave, right? Call that a delta wave. That's this slurred upstroke here, called a delta wave. And then another criteria that some people use, I don't know how good it is, I'll list it anyhow, is they say the PJ is normal. This is the J point here, at the end of the QRS, the J point. And they say that interval is normal. You can see that there's no difference between that and normal beat. So normal PJ. But these are your major criteria for Wolff-Parkinson-White. Okay, any questions then about the criteria for for Wolff-Parkinson-White. Okay, what important, yeah.
Is that the important lead where example?
Well, it depends.
Where is the evidence conduction?
It depends. The aberrant conduction pathway can go either to the right ventricle or to the left ventricle. And you can see it in the varying leads. As a matter of fact, they have what they call 3 types of Wolff-Parkinson-White, with type A, type B, and type C. And in type A, the pathway goes to the left ventricle, and heads towards the right ventricle. So you see your delta wave in lead V1 in an anterior lead because it's landing in the back. It's landing in the back of the heart, this aberrant pathway, and heading towards the front. So you see your delta wave coming towards you if you were standing at V1. The delta wave comes towards you. That would be called a type A. Easy way to remember it, if you want to remember this is roundsmanship really, is that in type A, the delta wave comes anterior, right? And for the most part, for practical purposes, everything else is type B. Type C is so rare that it's not even worth talking about. So just remember, in type A, the delta wave comes anterior, if you want to remember it. Okay, so then there's a type B where the aberrant impulse is like this and lands in the right ventricle, usually heads towards the left. And then there's type C, which I don't think I'll talk about at this time. Okay, what's the importance of the Wolff-Parkinson-White syndrome? I mean, so what if somebody has this? There's several things that you should know about it, at least 2 major important things. What do these patients develop? Episodes of what? Paroxysmal supraventricular tachycardia, usually PAT. These patients are subject to episodes of PAT, rapid heart beating. So anybody that has episodes of palpitations, a young person, heart rates go up around the 200 range, you should check them when their rates are normal to see if they don't have the Wolff-Parkinson-White syndrome. Okay, so that's one important, is episodes of PAT. The other reason that's important is that in certain leads, these delta waves, if you're not thinking about it, can look very much like Q waves. So, for instance, you can see something that looks like this. See, this would be your delta wave here, now heading downward. So this can look very much like a Q wave. So you could, if you're not thinking about Wolff-Parkinson-White, you can make a misdiagnosis of infarction. And this has unfortunately happened in the past. There are case reports in the literature of young persons who have been made cardiac cripples by someone looking at their electrocardiogram and reading it as infarction and saying that they had coronary disease when they just really had the Wolff-Parkinson-White syndrome. So don't misdiagnose anyone as having an MI. Well, it has all the other criteria. You have a short PR and you have a prolonged QRS. And when we go through our routine of how to read an EKG, we should pick up the QRS prolongation and the short PR long before we ever come to a question of whether the patient has an infarction. Okay. Now, going around the other way, though, how do you read an infarct in someone with WPW? Now, that's difficult. Okay, it's difficult to interpret infarctions in the presence of a patient who has a Wolff-Parkinson-White because you've altered the normal sequence of activation. Another point I just want to make about Wolff-Parkinson-White, well, we know just to reiterate, the 2 clinical important things are, one, is that these patients have episodes of PAT, right, supraventricular tachycardia, occasional PAF, paroxysmal atrial fibrillation. And the other thing is the misdiagnosis of MI. I think that's important to remember. Okay, the other thing that might aid an understanding of some of these terms is you'll notice that you have aberrant activation up to that point, right, up to that point. And then the rest of the activation is normal. What kind of beat do we call that? In other words, you have activation coming down this way and meeting activation coming the normal pathway. So what type of beat do we call that? That's a fusion beat. So we call that a fusion beat. The fusing of the activation coming from above and from, or by the aberrant pathway and then by the normal pathway. We call that a fusion beat.
It appear and then go,
Varies from one patient to the next. Some people have it all the time, and others it's just there part of the time. Some people have it alternating from one beat to the next. One beat's normal, the next beat shows WPW. There's a tremendous variation. Some people, some patients will have it between attacks, and then when they have attack of supraventricular tachycardia, you will not see it, and you won't see any evidence of it until they return to normal sinus rhythm. And other patients, they'll come into the emergency room with WPW looking like that. Looks very much like ventricular tach. That's another mistake that people make. So it can present in any way, and these patients don't have to have it all the time. Okay, any other questions then? Well, let's get back to our original diagram here then. Now let's take a situation where below the junction, we're now below the junction, the conduction through the ventricle is just generally slow conduction below the ventricles. Not that any one side or another is blocked, but the entire conduction through the ventricles is delayed or slow. What do we call that? No, first degree block refers to PR prolongation. No, an incomplete block usually refers to an incomplete block on one of the bundles, something like that. We call this intraventricular block. IV block, intraventricular block, and that's what we're talking about now. Intraventricular block. Did I spell that right? I spelled it wrong. Okay. Now, intraventricular block occurs. Here you have a normal electrocardiogram. Right? You take out the patient and it's normal. Right? You take it a few hours later and you have intraventricular block has developed. And the EKG looks exactly the same, except everything is spread out. It's gone from this situation to everything just spreads out. Okay, slow. It looks as if someone has taken the paper speed too fast. It's taken it at 50 millimeters a second instead of 25 millimeters a second. How would you differentiate the two, by the way? True intraventricular block from someone taking the paper at too rapid a speed. Right. You might look at the PR interval, for instance. If the PR interval is also twice normal, the QT is also twice normal, then you suspect that it was taken at twice normal paper speed. So you can differentiate. The most common cause of apparent intraventricular block probably is technical error, taking the paper speed too fast. All right, so you have a wide QRS. Now, what types of things can produce that? Okay, actually, you're right in a sense. Advanced myocardial disease. Some cases of advanced myocardial disease. When you have fibrosis or scarring or an infiltration of the entire conduction system with disease, you can wind up with, excuse me, you can wind up with slow conduction. Okay, what other kind of things can produce it? Some very important, pardon? No, actually not, unless it were to fall in this general category, advanced myocardial disease. No, certain drugs such as what? Quinidine, right. Quinidine and pronestal. And this is quinidine and pronestyl toxicity. When you give those drugs to a patient in high doses, this indicates toxicity and that you should really back off. Okay, some patients have renal disease. You give them a normal dose, and they'll develop evidence of quinidine toxicity. So in any patient on quinidine, you should realize that that intraventricular block is a manifestation of quinidine toxicity or pronestyl toxicity. Okay, what is another reason? Another very important reason, and that's hyperkalemia. This is advanced hyperkalemia. We see several patients, we had one just a few days ago, came into the hospital with a potassium of around 8 to 9, and he presented as intraventricular block. So these are the three primary causes.
Would he present his intraventricular block without other things like T waves?
Right. Once they develop the conduction disturbance, you get secondary T wave changes. You may not see the T wave peaking. Okay. As a matter of fact, these patients look like they have complete heart block very frequently with an idioventricular rhythm. But the only thing that's a little bit suspicious about it is that idioventricular rhythm is going along awfully fast. In other words, the rate is generally normal. Rate's usually 60, 70, 80. It looks like an idioventricular rhythm, patient going along at a normal rate. No, not that I'm aware of. Okay, so that's intraventricular block. Okay, now let's just stop here and consider what we're doing. We are attacking an approach to the QRS complex. What we're going to do when we look at an electrocardiogram is we look at the QRS to decide whether it's wide or not, right? Once it's wide, greater than 0.10, we have to consider, why is it wide, okay? So what I suggest is you look at the QRS to decide which portion is prolonged. Is it the beginning that's causing it to be prolonged? Is it the whole thing? Or are you dealing with a terminal conduction disturbance? Like that. Okay? So, you already know, if the beginning is prolonged, you're dealing with what? Wolff-Parkinson-White. If the whole thing is prolonged, intraventricular block. And then these terminal conduction disturbances deal with the fascicular blocks. Okay? All of the fascicular blocks, whether it be right bundle, left bundle, etc. And we're going to talk about those now. Okay, so let's talk about fascicular blocks. Fascicular blocks. Okay, and back to our conducting system here. Basically, we have three fascicles. Three major fascicles. Okay, this is the right bundle. And then we have two divisions of the left bundle, the superior division and the inferior division. Okay, those are the three fascicles, the three major fascicles. Okay, right bundle, left bundle, and the left bundle contains a superior division and an inferior division, also known by a lot of people, just to confuse you, as the anterior and the posterior division. As a matter of fact, most people write about it as anterior-posterior division. I think it's much easier to understand if you think of it as superior and inferior, and you'll see why as we go on. All right, now, these are the three major fascicles, and really what we're going to be talking about primarily today. But I just want to add that other people say, as well, they divided it into a couple of more, just to be complete. They say the common left bundle is another fascicle. That makes 4. And we will be talking about common left bundle. And they say you can also interrupt between here and here, somewhere around the bundle of His, in which case you'd have complete heart block. So there's 5 potential places that you can interrupt this system and wind up with varying combinations of blocks. But I think clinically, well, possibly clinically, they're all important. So let's say that these are the 5 potential places you can block. 1, 2, 1, 2, 3, 4, 5. And you can see here that if we block at this point, that'd be complete heart block, right? If we block at this point, right bundle branch block. If we blocked here, common left bundle branch block. We blocked here, left superior hemi block. That would be a hemi block. And left inferior hemi block. Okay, well, let's talk about this a little bit and how to approach it. All right. Now let's say that you see a conduction disturbance on your electrocardiogram. Your QRS is wide, greater than 0.10. Okay, and you look at this and you say, it's in this category. It's a terminal conduction disturbance. It's a terminal conduction disturbance, all right? Now, your computer should tell you, next, look at V1 and V6. The next leads to look at are V1 and V6. Okay? Now here you have a couple of possibilities. Either you see this in V1, or you see something else, which I'll talk about in a minute. Okay, now here's your terminal conduction disturbance, this slurring, right? Okay, now this is the way to handle that. You see that slurring, and then you say to yourself, well, I'm looking at V1, and it's positive. It's in positive in V1. That means it's coming towards V1, right? In what direction is that? It's coming towards V1. What direction is that? Anterior. Okay. Now I look at V6, and it's going away from V6. So if it's going away from V6, which direction is that? It's going rightward, right? Okay, so now we have anterior and right. What anatomical structure in the heart is located anterior and to the right? The right ventricle. So you have a delay in conduction over the right ventricle. What can give you a delay in conduction over the right ventricle? A right bundle branch block. Okay, so that's the way you should approach that. Now the other possible thing that you can see something that looks like this. Okay. And in this situation, the initial part of this is the only thing that you can see which tells you that that you don't have really an intraventricular block where everything is spread out. Very early, you see a quick inscription. Everything else after that is delayed. So you have to look for that in the electrocardiogram. In other words, back to this picture here, all we're seeing is just a little bit quick initially, and then terminally everything's spread out. But this is still called a terminal conduction disturbance. In an intraventricular block, you will not see this. Everything will be spread out. If this were an intraventricular block, you'd see something that looked like this. Right? Okay, then, and V6 looks like this. Spread out. Okay, now you ask yourself the same question here. Negative in V1, so which direction are we going in? Posterior. Positive in V6, so which direction are we going in? Lateral, left. Okay. Leftward, posterior. What's located left and posterior? Okay, so you have a delay over the left ventricle. What'll give you a delay over the left ventricle? Left bundle branch block. Okay, so that would be a left bundle branch block. So this is a right bundle branch block. And this is a left bundle branch block. Okay, now, here? This is all R. You usually don't see any Q. And you're right. At times you may see something that looks like this. You'll see, actually it'll work both ways. You'll see something that looks like this. You look at V1, and then you look at V6, and you may see that. Right, then you're saying you're stuck, right? This is going posterior, and to the right. Okay, what's located posterior and to the right? In other words, what I'm saying is which is more important, right and left or anterior and posterior, in terms of differentiating right from a left bundle branch block? Right, posterior or anterior. So in other words, what I'm saying is if there's any disagreement between these two, so that you're not sure, always pay attention to V1. Because basically, the right ventricle is an anterior structure. It should be much better have been called the anterior ventricle than the right ventricle. And the left ventricle is a posterior ventricle. Okay? At least electrocardiography. Well, okay. So we're along that far. Now, we can differentiate right from left bundle branch block, right? By looking at V1 and V6 with no trouble whatsoever, right? All we have to do is look at the delay and the conduction and figure out whether we're over the right ventricle or the left ventricle. We have either a right or a left bundle branch block. Okay? Now, after we've done that, that's step number one. Look at V1 and V6. Step number two is to go back to the frontal plane and look at the axis. So one, you look at V1 and V6. And two, you go back to the frontal plane. And you measure the axis. Okay, now if your axis, and there's some disagreement exactly, some people say minus 60, minus 30 should be the cutoff line, but it's somewhere that's probably in between that. If you have an axis which is normal, or let's say let me hold up on that again. The axis for an uncomplicated left bundle branch block, a pure left bundle branch block, going back to that original diagram of the left conducting system here, and here's the right. Okay. So what I'm saying is if we have a block here, common left bundle, we will wind up with an axis of 0. The axis will be approximately 0, roughly 0. So we can say if the axis is 0, that would equal to a left bundle branch block, common left bundle branch block. It's actually the mean axis. The terminal axis tends to go up a little bit more. I'm talking about mean axis now. Okay, now if you have a block of your superior division, okay, that'll give you the left bundle branch block, as we described before, plus a left axis deviation. If we have a block of the inferior division, we'll have the left bundle branch block V1, V6, plus a right axis deviation of greater than 120 degrees. That means it should be coming around in here someplace, in this general area. Okay, maybe I'm confusing you. Let's just put the formula down here.
Deviations?
Pardon?
Can you explain why you get right axis deviation?
Yeah, I will. Okay, let's make a little table first, though. Let's see. So we have a left bundle branch block by looking at V1 and V6, right? Plus a normal axis, or axis 0, right, is equal to common left bundle branch block. Okay, here again we have left bundle branch block plus left axis deviation, and we have a diagnosis of left anterior hemiblock. Here we have a left bundle branch block plus right axis deviation of greater than 120 degrees, and we have a left posterior hemiblock. Okay? Now you can also play some other games with this and say, well, these are just your unifascicular blocks, what I've drawn here, single fascicle blocked. And then you can just have an isolated right bundle branch block. Okay. Here's a common bundle block. Here's another division block, or single divisions block, and you're winding up with these situations. That would just be a right bundle branch block. And this axis for a right bundle branch block is generally around plus 90, approximately plus 90. Okay, now you have other situations where you can have bifascicular blocks. Bifascicular blocks. In other words, you can get 2 out of the 3 of these blocked. Okay. Now let's take the situation, for instance, where you have right bundle branch block, and then you look at the axis, and you find out that you have a left axis deviation. And what you have really here is a right bundle branch block plus a left anterior hemiblock. Okay, perhaps this is getting a little bit, is it getting confusing? Getting a little deep? All right, let me just summarize then by just saying what you really want to do is you want to look at V1 and V6 first, right, and decide whether you have a right or a left bundle branch block. Now, depending on what your axis is, will determine which fascicle of that bundle is involved. Okay? And in certain situations, such as right bundle branch block, if you have a left axis deviation, that may mean you may have 2 fascicles involved. And different combinations may mean that you have other combinations of fascicle involvement. And the importance of it is that as you obstruct more and more of these branches, certain of these patients may go into complete heart block because you've lost all your conduction below the atrium. In other words, these fascicular blocks, or combinations of them, are a precursor in some instances of complete heart block. And it's said that patients with this particular combination, right bundle with a left axis deviation, about 20% of them will eventually go on to complete heart block. 20% complete heart block. If you have the other combination, and I'll just finish this at this point, right bundle branch block plus right axis deviation, which is a right bundle branch block plus a left posterior hemiblock, 80% of these go on to complete heart block. So this by itself, some people think, is an indication for a pacemaker. That's the importance of it. 80% complete heart block. So we've talked about unifascicular blocks here, bifascicular, which is combinations, and then you can go on to trifascicular block. And trifascicular block is will in a very short time become complete heart block. Okay? If you have somebody in bifascicular block, and then they start developing AV block, as evidenced by 2-to-1 block or PR prolongation in addition, this means that they are imminent in terms of cutting off their conduction below the junction. So this is something, just a concept possibly, that you should be aware of. Okay, now someone asked me, what is the mechanism for the left axis deviation or the right axis deviation? And I'll just explain that very briefly. Here's your heart again. Here's your ventricles. And if you block the superior division, let's say you block the superior division of your left bundle. Now, the only places the impulses can go is down to the right ventricle, and they can go down the inferior division in the left ventricle, right? There's an area up here which is not yet activated, right? So this area here is activated late after everything else is all done. So therefore, you wind up with an axis or a vector which tends to go up in this direction towards that unactivated portion of the ventricle. So you wind up with a left axis deviation, and the reason for the right axis deviation is just the reverse. You block this division, you have activation here, you have activation down here, but you have an area in the middle here which is not activated until late. So you have a late vector which is coming rightward and inferiorly.
How do you get 0 degree axis with common?
Well, it's probably a neutralization, I don't know, but it's probably a neutralization out of these two vectors, one going this way and one going this way. So the mean probably going this direction. That looks like a pretty good mess there. I'm sure that I've probably confused you a little bit in terms of looking at the hemiblocks. But to reiterate, I think the important things are, what you do is you look at the QRS. If the initial portion is prolonged, the whole thing is prolonged, or the terminal portion is prolonged. There's no problem with these two, right? It's this one, okay? If you see this situation where the terminal portion is prolonged, the first thing you do is you go look at V1 and V6, right? And you decide whether you have a right bundle or a left bundle. Simple as that. We're all right so far? Then, after you're finished with that, then you go back to the frontal plane and measure your axis, right? If you measure your axis in the frontal plane, then you can talk about whether it's a left axis deviation or a right axis deviation or an axis of 0, things like that. And then you can, and whether you're dealing initially with a left or a right bundle, will tell you whether you have one of these combinations or one of these hemiblocks or bifascicular blocks.
A couple of other things.
One is the concept of peri-infarction block, which was talked about before. I can go over this fairly quickly. Now, peri-infarction block by definition means block around the area of an infarction. Okay? Peri means around the area of infarction. So let's say that you have an infarction here in your left ventricle someplace. Okay. So the first thing you need in order to diagnose peri-infarction block is signs of an infarct. Okay, so that's criteria number 1. So you need signs of an infarct. Okay, the second thing you need is signs of a conduction disturbance, right? And signs of a conduction disturbance are a QRS of greater than 0.10. Okay, now what happens when you have an infarct is you have your forces going away from the area of an infarction, right? So that's why in an inferior infarct, for instance, you develop a Q wave, because the forces are going away from the inferior wall. So you have forces first going away from the area of the infarction, and then after the whole heart is depolarized, you have an area around the infarct which is finally being depolarized very late because there's a block around that area, peri-infarction block. There's a block around the area of the infarction. So you have a late return of the forces towards the area of the infarct. Okay? In other words, what you'll see is, on the electrocardiogram is you'll see your Q wave, and then you'll see a prolongation of the QRS coming back towards the original area. First going away with your Q wave, then returning with the delayed R. Okay, now, so another criteria is then that the initial forces and the terminal forces have to diverge by greater than 120 degrees. You have to have a wide spatial angle between the initial 0.04 second vector and the terminal 0.04 second vector, which means that if you vector out the beginning half of this thing and you vector out the end of this thing, this may be the initial and this will be the terminal, and they'll have a wide spatial angle in between. So that's the third criteria. So you have angle of greater than 120 degrees between the initial and the terminal 0.04 second vector. Well, you take the whole electrocardiogram and you plot the axis of the initial and the terminal vectors just as by the method that we described for plotting axis the first day.
Plot the axis as you look for the equipotential.
Yes, right. Well, you look for the equipotential point in just the first half. You forget about the second half, say. You forget about the second half of the QRS. Just look at the first half of it and say, where's the first half isoelectric? Okay.
How about the Q wave? How would you describe the Q wave? Deep
Significant
wave?
Q. A significant Q.
Not deep.
Deep is significant. Or like significant is a deep one. Greater than 0.04 seconds in duration and greater than a third to a quarter the height of the R wave. It's criteria of significant Q. Okay, these infarcts are located really on two surfaces. The inferior surface, in which case you'd call it diaphragmatic peri-infarction block. You'd see your Q waves in 2, 3, and AVF, right? Signs of your infarction, your inferior surface, 2, 3, and AVF, and forces returning. So that would be a diaphragmatic peri-infarction block. And the other types are located in the left precordial leads, 1 AVL, V4 through V6. In that case, we'd call it anterolateral peri-infarction block. So inferior would be diaphragmatic peri-infarction block, and then the lateral surface with your infarct Q's located 1 AVL, V4 through V6, and we call it anterolateral peri-infarction block. Okay, this is a term that's not being used so much anymore. A lot of people think that the peri-infarction blocks overlap with some of the hemi-blocks, but this is something that you still hear talked about, and it's nice to know at least the concept, nothing else.